The title of our study is Partial Weight Bearing Produces High Interfragmentary Strains in Distal Femur Fractures. This work is a shared first authorship between myself, Peter Swarzenberg, and Jordan Inacio. We have been working in close collaboration with the Department of Orthopedic Surgery at St. Luke's University Hospital. Distal femur fractures comprise 6% of all femur fractures. These fractures are challenging to treat due to high occurrences in poor quality bone, complex fracture patterns, and different constructs to treat them, including the lateral plates seen here. In this study, we have a wide range of fracture patterns and bridge spans across the cohort. One challenge in studying these fractures is how to model them. The established biomechanical model for bench testing and finite element modeling is an osteotomy, like the one seen here. This is supposed to represent an unstable suprachondral fracture. You can see on the animation that under axial loading through the femoral head, the fracture line experiences combined compression and shear motion. The models on the right show a complex strain field. In this study, we will be looking at von Mises strain. That takes into account volumetric deformation of compression or dilation and shear deformation or shape change. Many bench tests and finite element models have shown increased motion and strain at longer bridge spans as shown here. But how representative are these models of the types of fracture scenarios that are encountered in the clinical practice? Here you can see a CT scan of a patient with a distal femur fracture. Clearly, this is much more complex than the osteotomy case. The objective of this study was to characterize the interfragmentary strain environment for real fracture patterns using patient-specific finite element modeling. The patients in this cohort had a wide range of ages, BMIs, and fracture patterns. As you will see in the coming slides, treating these types of fractures can be extremely challenging. Developing these models starts with the pre-op CT scan, which is obtained for almost every patient with a distal femur fracture. The challenge from a modeling perspective is the scan is typically only the distal third of the femur. This means we have no way to apply loads and boundary conditions through the femoral head that represent weight bearing or replicate physical test methods. To obtain a full femur, an intact femur was scaled to each patient-specific model using condylar width. Next, each fragment was individually fitted to the scaled intact bone using a spatial registration tool to best match the surface contour between the two fragments. This was repeated for all fragments until the fracture was anatomically realigned. If there was an intra-articular extension of the fracture line, the distal fragments were fused to replicate the first stage of the surgical procedure, which is interfragmentary compression with a lag screw. Next, the proximal most fragment from the scan was merged with the intact proximal femur to create the model shown on the right. The reconstruction process was repeated for all 6 patients in the cohort. All 6 reconstructed models can be seen here. The models are to scale with each other to highlight the diversity in the patient femoral length and fracture patterns. Working with the orthopedic surgeons, we created a hardware model to match what was used clinically in each patient. For those of you who don't know, bridge span is the distance between screws across the fracture line, and these patients had bridge spans ranging from 26 to 134 millimeters. The models were meshed for use with finite element analysis, and element-wise material properties were assigned based on the underlying CT radiodensity for bone regions. The boundary conditions in the finite element model were designed to replicate a bench test with a cardanic hinge on both the proximal and distal ends. Each patient had a load of 20% of their body weight applied through the center of the femoral head. Traditionally, bench test and finite element models assess construct stiffness, which is the loading force divided by deflection, where deflection can either be measured at the crosshead or the interfragmentary gap. Both of these techniques miss the 3D strain environment in the interfragmentary region. To address this limitation, we created a strain measurement region around the interfragmentary zone. This region had an elastic modulus many orders of magnitude lower than the bone or hardware so that it did not affect the stiffness of the construct. The strain measurement region allowed for the complex 3D strain field to be calculated and visualized within the fracture zone. Here we have the 3D visualization of the von Mises strain fields around the fracture line for the 6 patients respectively. There is a wide variety of fracture patterns and relative magnitude of the strain field during 20% weight bearing. We see a large and more intense strain field for patients that have a longer bridge span. The thresholds for this visualization were chosen to highlight the range of strain from 2 to 10%, because this has been widely reported in the clinical literature to being conducive to secondary bone healing. Now let's take a closer look. Clearly, there are large regions of strain stimulation that can drive the formation of callus, and locally, we can see some hotspots that are exceeding the threshold of 10%. Next, we'll take a look at the quantitative distributions of strain. On the left are two examples, one of which is a patient-specific model and one is an osteotomy case. First, we want to assess peak strains, and we do that using the 99th percentile. In general, there is a tendency towards higher peak strains in the patient-specific models compared to the osteotomy models across the same range of bridge span. Again, because we have this strain field around the 3D fracture lines, we can query how much volume of the interfragmentary zone is experiencing what strain state. If we look at the volume of elements in the 2 to 10% strain range, shown in gold, we see large volumes that are experiencing strains that have been reported to be conducive to secondary fracture healing. All of the patient-specific models represent cases that went on to successful clinical union. This is interesting because in addition to the large regions in the 2 to 10% range, if we look at the region greater than 10%, we see that in the patient-specific models, there tended to be notable hotspot zones. However, this only occurs in a few of the patient-specific models. So why is this happening? 3 of the models had 99th percentiles below 10% strain and are now grayed out. However, 3 of the models had 99th percentile strains above 10%. We noticed that 2 of these corresponded to very long bridge spans. So then we looked at the correlation between interfragmentary strain distribution and bridge span. First, as a sanity check, we looked at the overall construct stiffness versus bridge span. Overall, in both the patient-specific and osteotomy models, the stiffness decreased with increasing bridge span, which is consistent with many published results. We then correlated the volume of elements in the different strain ranges with the bridge spans of all of the constructs. Focusing our attention now on the relationship between strain hotspots and bridge span, we see that the OTA 33A3 osteotomy does not produce peak strains that are similar to the patient-specific models, even at very high bridge spans. Reflecting on everything that we have learned, this study shows that strain is higher in patient-specific models compared to the osteotomy models that have traditionally been used to study distal femur fracture fixation. This is important because the context of the study is the current clinical debate. Is immediate weight bearing as tolerated safe for distal femur fractures? This study assumes that patients who have non-weight bearing post-operative instructions will do no more than 20% light toe touch weight bearing. However, patients may be applying significantly more load to their implant. We know that strains will be higher at higher loads. This indicates that in vivo healing of distal femur fractures may be more robust to localized high strains than has been previously appreciated. Thank you for viewing this presentation. If you have any questions, please feel free to reach out to Jordan and I. We would love to talk more about this exciting work.